Hello everyone, I am Dr. Deepak and I'll be talking about stroke and localizing and management of the stroke. Uh, I'm very passionate about this topic because of the intricacies of the localizing lesions and how a proper management can help the patient recover well. So let's dive into the topic. Before starting talking about the localization management, I just want to give you a brief explanation what the stroke is. So stroke is an abrupt onset of focal neurological deficits that can be attributable to any vascular cause. It should be differentiated from the transient ischemic attack with the help of timing. So in case of stroke, the symptoms last more than 24 hours, but in the case of transient ischemic attack, symptoms last less than 24 hours. And so the stroke is classified based on etiology, location, and the artery involved. Based on etiology, it can be classified as ischemic, hemorrhagic, and embolic. Based on the location, it can be cortical, subcortical, and brainstem. And based on the arteries involved, it can be divided into anterior circulation and the posterior circulation. Based on internal carotid artery, so in case of anterior circulation, we'll find anterior cerebral artery, middle cerebral artery, anterior choroidal artery, and the internal carotid artery. In case of posterior circulation, vertebral arteries, basilar artery, and the posterior cerebral arteries are involved. Coming to the anterior circulation, these are the four major arteries that are involved in the stroke. We'll discuss one by one. Coming to the middle cerebral artery, which is the most common place to have a stroke. We'll discuss about the blood supply. So the middle cerebral artery rises from the internal carotid artery and gives a branch of lenticular striate artery where it supplies striatal parts such as putamen, outer globus pallidus, and caudate nucleus. And when it gets infarcted, the patient develops hemibalismus. And it also supplies to the internal capsule. So the internal capsule has a topographic representation of the body where when the geno gets involved, the patient develops ipsilateral facial weakness and the contralateral clumsy hand syndrome. And in the case of posterior limb involvement, the patient develops ipsilateral arm and leg weakness. And it branches into superior division and the inferior division at the level of sylvian fissure, and where these branches supply the superior lateral surface of the brain, and superior division supplies the superior parietal cortex and the frontal area, and the inferior division supplies parieto-temporal cortex. And these are the symptoms that occur collectively in case of infarction in the superior division or in the case of inferior division. We'll discuss each area one by one. So the middle cerebral artery supplies the superior lateral surface of the brain where the somatosensory area and the motor cortex area gets involved. So this is a topographic representation of these areas. And this presentation is called homunculus, where we can see each part of the body represented on the superlateral surface of the brain. So in case of middle cerebral artery occlusion, the sensory area and the motor cortex area gets involved, and the patient develops sensory loss and the sensory loss over the contralateral face, arm, and leg, and the contralateral paralysis of the face, arm, and leg. And the other areas over the superlateral surface of the brain that gets involved in the middle cerebral artery occlusion are the speech areas such as Broca's area, where the patient develops motor aphasia, where the patient is able to comprehend the language and able to understand what's written on the paper, but they won't be able to speak out properly. And in case of Wernicke's area, the patient develops sensory aphasia, where the patient finds them unable to comprehend the language and unable to read over the paper. And they have a fluent speech. And there is a frontal eye field on the superlateral surface of the brain where both middle cerebral artery and the anterior cerebral artery supplies. But in the case of middle cerebral artery occlusion, the frontal eye field gets involved more occasionally than anterior cerebral artery occlusion, and the patient develops conjugate gaze palsy to the opposite side. And it also middle cerebral artery also supplies parieto-occipital cortex of the dominant hemisphere, where the patient develops lexia, agraphia, acalculia, finger agnosia, and the right to left confusion. And these symptoms collectively called as Gerstmann syndrome. And there is a subcortical involvement where the temporal optic radiation gets involved. So the temporal optic radiation runs from the lateral geniculate body and ends in the visual cortex of the occipital lobe. When it gets involved, the patient gets superior homonymous quadrantenopia, and this is how the visual field defect can be seen. Coming to the anterior cerebral artery. So the anterior cerebral artery is divided into precommunal part and the postcommunal part based on the anterior communicating artery joining in between. So the anterior communicating artery runs from the contralateral anterior cerebral artery, where it can supply the postcommunal part even when the precommunal part gets infarcted. So the precommunal part supplies the anterior limb of internal capsule, anterior hypothalamus, and the head of caudate nucleus and other areas. So the postcommunal part supplies the perforating branches to hypothalamus, septum pellucidum, fornix, striatum, and the corpus callosum. In case of anterior cerebral artery occlusion, there is only small place of superior lateral surface of the brain where the anterior cerebral artery occlusion infarcts can be seen, especially in the medial surface of the posterior frontal lobe, where the patient can develop contralateral grasp reflex, circling reflex, and the paratonic rigidity. And coming back to the homunculus, this is a representation of the body over the motor and somatosensory area, where the patient, in case of anterior cerebral artery occlusion, the patient develops sensory and motor loss over the lower limbs, and patient finds themselves unable to move their lower limbs and cannot feel the sensation over the legs. And on the medial surface of the brain, the posterior medial part of the superior frontal gyrus can be involved, and the patient develops urinary incontinence. And in the case of corpus callosum involvement, the patient develops dyspraxia and tactile aphasia of the left limbs, which can be described as patient won't be able to identify the object when they ask to identify the object only with the touch. Coming to the anterior choroidal artery, so this artery strokes are very rare in occurrence because of the dual blood supply from different branches of the other middle cerebral artery and other arteries, and it can be seen most commonly in case of iatrogenic cause due to clipping of internal carotid artery when it gets involved with aneurysm. So in case of anterior choroidal artery occlusion, the patient develops stroke over these areas, that is in between the posterior limb of internal capsule and the surrounding white matter, where when it gets involved, the patient develops hemiparesis, hemianesthesia, and the homonymous hemianopsia, because the optic radiation runs in between the internal capsule and the white matter. And coming to the carotid artery occlusion, so the internal carotid artery occlusion or stenosis involves the ipsilateral half of the brain and can be identified with an important sign, which can be identified as recurrent transient monocular vision loss. And clinically, we can hear the carotid bruit, but as the stenosis increases, the flow decreases and the bruit gets decreased. So patients without bruit cannot be ruled out of the carotid artery stenosis. And in case of common carotid artery occlusion, the patient will have similar findings as of internal carotid artery symptoms, along with the jaw claudication. And we usually find bilateral common carotid artery occlusion in case of Takayasu arteritis. Coming to the posterior circulation, the first most common artery is posterior cerebral artery. It can be divided into P1, P2 based on the posterior communicating artery that runs from the contralateral posterior cerebral artery. So P1 supplies the midbrain, subthalamus, and thalamus, and the P2 supplies temporal and occipital region of the cortex. So P1 gives a interpeduncular branches that supplies the medial area of the midbrain. When it gets infarcted, the patient develops infarction over the corticospinal tracts, corticopontine tracts, red nucleus, and the oculomotor nerve exiting out of the midbrain. So the patient develops contralateral hemiplegia and ipsilateral oculomotor nerve palsy and ipsilateral ataxia. Coming to the P2 artery occlusion. So the P2 artery has a very long course where it supplies blood to occipital area, corpus callosum, and the medial surface of the temporal lobe. When the primary visual cortex of the occipital lobe gets involved, the patient develops homonymous hemianopsia, without macular sparing. And in case of visual association area involvement, the patient develops tunnel vision, which can be called as Balint syndrome, and the patient will have a distortion of the image, which can be described as palinopsia. And in the case of hippocampus and medial temporal lobe involvement in the dominant lobe, the patient can have the memory deficits. This involvement of splenium of corpus callosum can give the patient hemispheric disconnection, and associated with the dominant occipital lobe involvement, the patient can develop alexia without agraphia, and patient will be having visual agnosia for faces, colors, and objects. And coming to the basilar artery, even though this has a very short course of supply, it has multiple branches, and it supplies very vital areas of the brain. So the branches are paramedian branches, short circumferential branches, superior and anterior inferior cerebellar arteries, interpeduncular branches. And these supply various structures such as corticospinal tracts, corticobulbar tracts, spinothalamic tracts, few nuclei, and the cranial nerve nuclei from 3rd to 8th cranial nerve nuclei. In case of basilar artery occlusion, in case of especially in the partial basilar artery occlusion, the patient develops ptosis, pupillary asymmetry, lack of reaction to light, and somnolence. And in some cases where the complete artery occlusion, complete basilar artery occlusion occurs, the patient develops locked-in syndrome, where it can be described as state of wakefulness and awareness with quadriplegia and paralysis of multiple cranial nerves. And it makes the patient unable to speak, move, or communicate except with the eye movement, or they can only use eyes to communicate. And in case of basilar artery occlusion, we can find hyperdense basilar artery in the non-contrast CT. And vertebral artery. Vertebral artery has a very long course where it supplies both intracranial and extracranial structures. Occlusion of this artery has variable symptoms, out of which the medial and lateral medullary syndromes are important. And coming to the brainstem strokes, this is a short representation of cranial nerves, tracts, and the arteries involved at various levels of the brainstem. We'll discuss first medial syndromes, and then we'll go to the lateral syndromes. So in case of medial syndromes, if the posterior cerebral artery gets involved, the patient will develop 3rd, 4th cranial nerve palsies along with the involvement of corticospinal tracts involvement. In case of basilar artery occlusion, the patient will develop 6th cranial nerve palsy along with the corticospinal tract involvement. In case of anterior spinal artery occlusion, patient will develop 12th cranial nerve palsy along with the corticospinal tract and the medial lemniscus. Coming to the lateral syndromes. In case of anterior inferior cerebellar artery involvement or superior cerebellar artery involvement, the patient will develop 5th, 7th, 8th cranial nerve involvement along with the medial lemniscus and the spinothalamic tracts. In case of posterior inferior cerebellar artery, the patient develops lateral medullary syndrome where the 9th, 10th, 11th cranial nerves gets involved along with the spinothalamic tracts. And these are the few complications that can be seen in the stroke, such as dysphagia, which can be found in patients with bulbar dysfunction, and if they were given with oral feeds without assessing the swallowing mechanism, the patient can develop aspiration pneumonia. And because of the prolonged catheterizations, patient can develop urinary tract infections, and because of the prolonged immobilization, patients have a risk of developing deep vein thrombosis, and it can propagate to lungs and cause pulmonary embolism. And usually patients with stroke are associated with dehydration and malnutrition. And sometimes patients can develop muscle contractures and pressure sores as well. Coming to the treatment. So these are the goals of the treatment for the patients with stroke. So first we have to stabilize the patient, and we have to treat the cause, and we have to determine whether the patient is eligible for thrombolytic or endovascular therapy or not. Coming to the stabilizing the patient with stroke. First, we have to assess the airway, breathing, and circulation, where in case of patients with loss of consciousness and the bulbar dysfunction are more prone for airway obstruction, and And patients can also develop hypoxia, which can be described as oxygen saturation less than 94% and require supplemental oxygen. Simultaneously, we'll take the history, and one of the important factors in the history is time of onset of the stroke, where we can assess the patient for the eligibility of giving thrombolytics or not. And few features in the history that can identify the cause of stroke or head trauma, cardiac murmurs, irregular heart rate, that can give an emboli, and the recent surgery or prolonged immobilization. And with the history, we can rule out some disorders that can mimic stroke, such as seizures, hypoglycemia. Coming to the physical examination, we have to assess the patient from examine the patient from head to toe, so that we can find few signs of the cause, or we can rule out few other disorders that can mimic stroke. So coming from the head, we can, if the patient has history of head trauma, we can go for intracranial hemorrhages or subarachnoid hemorrhages. And if we can assess the fundoscopic examination for papilla edema or cholesterol emboli, that can give us the possibility of stroke because of the emboli that arises from the bacterial endocarditis, and present of tongue laceration. New tongue laceration can identify the patients having had a seizure, and presence of vascular bruit over the neck can give us a localization of the cause, that is internal carotid artery occlusion, and cardiac auscultations or murmurs, and abnormal breath sounds, stridor or fluid overload, and other findings such as signs of recent surgeries and invasive procedures that can cause intravascular atherosclerotic plaques that can cause a stroke, and presence of DVT, cellulitis, and distal ischemic emboli can give us a uh, give us a description of how the patient developed stroke because of the uh, emboli that developed from the thrombus. And coming to the neurological examination, we'll assess the patient based on motor findings, sensory findings, and any other symptoms. And we should confirm the provided history with the neurological assessment. And sometimes we can assess the outcome and severity with the few scales that can be used to identify, such as National Institute of Health Stroke Scale. It consists of 11 components, and out of which 3 are the most predictive factors for the diagnosis of stroke. The facial paresis, arm drift or weakness, and the abnormal speech. And we have to send some immediate lab studies to identify stroke, such as non-contrast CT with CT of the head within first 4.5 hours after the onset of the stroke. And if the patient history doesn't mention any time of onset of stroke, we can go for MRI with diffusion weight imaging that can give us a proper timing of stroke happened. If the stroke happened within 4.5 hours within 4.5 hours, and finger stick blood glucose to assess hypoglycemia and oxygen saturation. Other lab studies that must be included are cardiac imaging for the first 24 hours. Must be done as a part of guidelines in the American Heart Association, and coagulation studies and the complete blood picture that includes platelets to rule out intracranial hemorrhages. After stabilizing the patient, we have to manage the patient. So we'll go one by one based on fluids, blood glucose levels, swallowing assessment, head and body position, fever, and blood pressure monitoring. Coming to the fluids, most patients that had stroke are associated with dehydration and volume depletion. So we have to give them administer isotonic saline without dextrose, which is the choice of the intravascular fluid for repletion and the maintenance therapy. Fluids which are hypotonic and hypotonic are contraindicated because the patient can develop cerebral edema with the hypotonic fluids, and patient cases with hypertonic fluid such as dextrose can cause hyperglycemia. Sometimes it can mimic stroke. And the patient blood glucose level should be maintained within 60 to 128 milligrams per deciliter, because in case of less than 60 milligrams per deciliter, the patient can develop hypoglycemia, which itself can cause a neuronal injury and can cause stroke, and it also mimics stroke. In case of hyperglycemia, it is a usual finding in because of the stress hyperglycemia, and At the cellular level, the patient will have increased tissue acidosis from anaerobic metabolism, free radical generation, and they can also have increased blood-brain barrier permeability and rarely mimics stroke. And swallowing assessment should be evaluated before allowing the patient to have oral feeds, because few patients with bulbar dysfunction can develop dysphagia, and the patient takes any liquids or food orally, they can have they can develop aspiration pneumonia. So the swallowing function should be evaluated before allowing the patient to have oral feeds. And head and body position, usually we recommend patients to be in a supine position, which is a neutral alignment within the body, and except in cases such as elevated intracranial pressure, aspiration pneumonia, or any cardiopulmonary decompensations or oxygen desaturations, we ask the patient to have the elevating the head of the bed to the 30 degrees. Fever, it is associated with unfavorable outcomes in case of stroke, and it also gives us an insight about the cause. It can be because of the primary central nervous system infections such as meningitis, subdural empyema, brain abscess, and infective endocarditis. And the most common etiologies of the fever in case of stroke are because of the aspiration pneumonia and urinary tract infections, which should be excluded at first. And the source of fever should be investigated and treated as soon as possible. And the antibiotics can be used to lower the temperature. And coming to the blood pressure management, in case of stroke, especially ischemic stroke, we do not alter any blood pressure in the first 24 hours unless the patient is eligible for the thrombolytics and the patient is having blood pressure over 185 or 110 mmHg. The blood pressure must be reduced less than 185 or 110 mmHg. And if also the patients who have blood pressure over 220 or 120 mmHg are patients with a heart condition such as ischemic coronary disease, heart failure, aortic dissection, they reduce BP blood pressure by 15% in the first 24 hours of the stroke onset. And after 24 hours, if the patient is neurologically stable with blood pressure over 140/90, we can start antihypertensive medication as soon as possible. And in case of patients with extra or intracranial artery stenosis, vascular imaging must be done before the before administering any antihypertensive medication. And even after starting antihypertensive medication, we reduce the blood pressure slowly over 7 to 10 days. And the drug of choice for the antihypertensive medication should have a characters of short life and the rapid onset. And the first line drugs that are used to reduce blood pressure are IV labetalol, nicardipine, clopidogrel, and the second line drugs are IV nitroprusside. And drugs such as nifedipine should not be used because of the long half-life. And the other interventions that should be used along with these management are antiplatelet therapy and statin therapy, which improves the patient's outcome over the time. And patients who had restricted mobility or prolonged immobilization, venous thromboembolism prophylaxis must be given. And we should ask the patient to have behavioral and lifestyle modifications such as smoking cessation, exercise, weight reduction, and Mediterranean diet for obese people. Thank you.